I'm drinking dirty chai again.
Oh, I'm drinking Starbucks blonde coffee.
Classic
Classic. Yeah.
Starbucks, yeah. Also, actually, I watched that Outcry documentary. I
Did
watched
you?
the whole thing. Yeah.
Well, that's a weird segue to prehab, but go ahead. Where do you want to start?
Well, I learned about prehab from you, but I know that you probably learned it elsewhere. So I think our viewers and myself included would be curious to know where you first heard about prehab and how you got involved in that.
Yeah, so let me start by saying that there's a great organization in Michigan, the University of Michigan Health System, that just does incredible work in general on surgical quality and patient safety. So I know in another podcast, depending on whether or not you release this one first or that one first, we talk about the work the University of Michigan did on opioid reduction in surgery. And they've also done some fantastic work on prehabilitation. So I first learned about prehab actually from the same person we mentioned on the opioid piece, from Dr. Mike Engelsbe. And for those who don't know Mike, he's a transplant surgeon out of the University of Michigan Health System. He's also the director of the Michigan Surgical Quality Collaborative, so that statewide Blue Cross funded quality collaborative. And I met him a number of years ago. Really, actually, I'd reached out and started talking to him about what we were doing back at in SeamlessMD several years ago. And he was telling me about some relevant work that his team was doing on prehab. And of course, I said, Mike, what the heck is prehab? I've never heard of this before. And kind of the way that he described it is very much about, hey, you know what? As you mentioned, Alan, when you have a surgery, your body's undergoing, major stressors. And kind of what happens if you, I wish that we could draw a graph on the screen here. But the idea is that, like, let's say you had on the y-axis a patient's physical function, and on the x-axis was time before and after surgery. What you find is that when a patient has surgery, because of the stress of opening up the body and manipulating and all that, your physical function declines, right? So that's why after surgery, you're in pain, you can't really walk, it's hard to eat, and so your function declines. And the idea is that over time, you try to recover back to your baseline. But the idea behind prehabilitation is that, well, what if you trained for the surgery? What if you strengthened your physical and mental status before the surgery so that your baseline function actually starts off higher because you trained for the surgery? So that way, when there is a dip in your function after the surgery, the actual dip is not as deep, and you're able to actually return to your baseline function faster. And so theoretically, what that means is that your body is able to get back to baseline sooner. You actually recover faster. Your length of stay is shorter. You're at a lower risk of complications, and so the patient's outcome is better. So basic theory is get stronger before surgery, and therefore recover faster after surgery. And that's prehab in a nutshell.
Preventing frailty and now is that when you're recovering to baseline after prehab, say after your surgery, the baseline, is that based on the initial assessment where your baseline was? They're not talking about you return back to the trained version of yourself, but back to baseline. Is that
I think people would be thrilled if you were able to return to your the new baseline you created when you trained for surgery. But I think that most of the goal was to get a bit strong before surgery and then get back to your original baseline at the very least. I think we'd love it if patients were able to maintain a new higher baseline, but I don't know if that's realistic for a lot of folks.
Right. And obviously, we wouldn't be bringing up this topic if there wasn't a ton of research on it. There's been...
Sorry, do you mind if I tell you one more story?
Please, yeah.
Yeah, so if you asked Mike Engelsbe, where did he learn prehab from?
Right.
And who actually point to Francesco Carli, who I think is one of the grandfathers of prehab, I think. And so for those who don't know Franco, he's this brilliant physician out of McGill in Montreal. And I believe Mike Engelsbe learned prehab from him. And I remember, I forget which conference I was at, but we ended up meeting with Francesco Carli. this like hotel lobby, and then he kind of was also teaching me from his perspective, like how he defined prehab. And you know, that graph that I was kind of drawing in the air, I was showing you. Franco actually took out a piece of paper and was like drawing that graph for me and using that to illustrate prehab to me. And so that really that's how I remember it from him. So anyways, like he's like a brilliant when it comes to prehab, and certainly for those who are looking for more info on like what's the basis for prehab, the work that both Mike and Franco have done have been very foundational, I think, for the prehab concept here.
And I know Franco's done a ton of work all across the world with research respect to prehab and enhanced recovery after surgery. They're very big and involved in quality improvement in general. Absolutely. In terms of the actual outcomes that are being improved from prehab, when I first learned about it, it's surprising. It's surprising how many outcome measures are actually improved by just implementing a prehabilitation program. I don't know if he even mentioned it's called prehabilitation. That's the actual term for it. Dr. Engelsbe's group out of Michigan, I know they started their prehab component, and they called it MSHOP, I believe, which stood for the Michigan Surgical and Health Optimization Program. I think what's really neat about their MSHOP or their prehab program is how they've been able to distill the information into very, very easy to understand concepts. And they've broken it down into like 4 easy groups. There's the movement, there's breathing, there's eating, and then there's relaxing. And
by the way, Alan, we do all those things already day to day. That's literally all I do.
Well, but I think it's quite interesting because they've taken those everyday things, but then they've actually put in protocols in place, and they've put in measures to ensure that their patients are actually following the specific instructions. And so things include, I know for like movement, as an example, would be like increasing activity through taking a number of steps, and it might be like take 5,000 more steps than you would do on a daily basis. With breathing, it's use the incentive spirometer and smoking cessation modules. For eating, it's obviously dietary recommendations, things like lean proteins, really beneficial for the prehab component. And then with relaxation, things like positive thinking and mindset building, even meditation I've seen in some programs as well. And what's really neat is the fact that they're almost open sourcing this project. They're making it available for anyone. They can go ahead and download their videos, their PDFs that they have. It's all on their website, and we'll link to that in the show notes as well.
Well, I'll tell you. I mean, let me tell you kind of how generous Mike and his team are when it comes to open sourcing this. So a couple of years ago, I had a family member who was going through a major surgery, and I reached out to Mike. Actually, I said, "Hey, Mike, do you mind sharing your latest prehab protocols?" And I just have a family member that I think would really benefit, and I'd really appreciate anything that you can share. And Mike said, "You know what, Josh? I'll do you one better. I will have our team actually mail a prehab package with the incentive spirometer which may not incentive spirometer, but like the DVD package and like the booklets and all that kind of stuff to that family member directly. And also we'll give you a hotline number. So if that person has any questions about how to do prehab, they can call anytime." And I said, "Oh my gosh, Mike, that's incredible. Like, that's so generous of you. Okay, how much does it cost? I'll pay for it. No problem." And he says, no, Josh, like, don't worry about it. We'll just send it. And this is the type of people that's part of that team. And so they clearly are like mission driven, well-intentioned, truly patient-centered. So, I mean, kudos to that team. They really worked hard to take this model and make it available to everyone.
Definitely. And that's across borders. Like that's
yeah. In Michigan.
Yeah. Wow. I know on that website, for instance, they've posted their earlier studies that they've done on prehab, and obviously they've been funded since then to do continued work and expanding across different procedures and more patient sample sizes and all that. But I think what's shocking to me is just by improving the patient baseline, the very first study that they've released, this was maybe back in 2010 or 2013. I don't have the date exactly on that, but it was a few years back. What was amazing was to see that there's actually a reduction in length of stay for a patient. So because their baseline function is better, they can recover a bit faster. Their body's more attuned to the physical stress of a surgery, and they actually reduced length of stay by like 2.3 days on average and that was like a 100 patient sample size versus control.
And Alan, just to like hop onto that, I think one thing that we should cover is that I think when people hear what prehab is conceptually, they think they might be already doing it, or it's common sense. So I think most surgeons or anesthesiologists or nurses would say, well, yeah, I do tell my patient to eat healthier. I do tell them to stop smoking. I do tell them to maybe be more active before surgery. But that's not what we're talking about, right? Like that's just table stakes. Like we're talking about like a prescriptive regimen. So just to give people a sense of like what they were doing in Michigan for this MSHOP prehab program. So, they were getting patients to achieve, I forget the exact number, Alan, but it's like a few thousand steps at least per day. And I think it increased. I think they're asked to do your best to increase it maybe like 500 steps more every day until you reach a plateau. And they'd have to track it. They'd have to record it. They'd have to send it back so that people know, are they hitting their steps or not? So there was accountability built into just meeting certain activity goals. It wasn't just telling a patient to exercise more. It was, no, your prescribed exercise. Same with the breathe aspect, which is using incentive spirometry. So patients are actually taught to do incentive spirometry daily for 2 weeks leading up to the actual surgery. So they were training their lungs to build their lung capacity. So again, it wasn't just telling the patient, hey, use it a few times. It was, no, you're going to do it for 2 weeks. We're going to track it. You're going to be compliant with it. And then same with, proper eating and positive thinking and all that. So it truly was like prescriptive. And so I think it's about like, if you empower the patient to follow those steps, of course they'll get stronger. If you just tell them theoretically exercise more, like that's not going to give an actual outcome.
Right. Or maybe a small percentage of patients will actually do that. But if there's no targets to meet, then how is it possible to have your patients to actually follow that?
Yeah, and just they were pretty innovative. Like they use even back like years ago, right? They were using pretty common technology. So I remember like patients were getting text messages or emails even years ago through MSHOP about how did you like do your spirometry today? How many steps did you walk? And then if they met their goal, they'd get positive feedback. If they didn't, they'd get maybe constructive feedback. So even back then, they were using technology to kind of scale out their efforts a bit.
I know that they expanded their initial study to a statewide thing. So obviously, Mike's really involved in the MSQC. Do you want to shed a bit of light on the state study that was conducted?
Yeah, so Mike's team ended up getting this CMS funded innovation grant. I think it was like $6 million or something like that to roll this out to multiple hospitals. They ended up, I think, rolling it to about 21 hospitals across Michigan. They had thousands of patients get prehab through this initiative, and they enrolled all kinds of patients who've had major inpatient surgery. So cardiac surgery, hernias, colons, transplants, HPB, thoracic, gynae. And they had, I think, 3,000 to 4,000 patients during a certain time period went through this. And then they actually published a really good article in the Journal of the American College of Surgeons, where they compared a bit over 500 patients who got prehab with 1,000 kind of case-matched patients with the same, comorbidities, demographics, et cetera. And long story short, they found that patients who got prehab were statistically significant reductions in length of stay by 1 day, and costs or total costs for up to 3 months after surgery were about $3,200 less for patients who went on prehab. And so they demonstrated in a much larger sample set in a well-designed study that prehab, and I'm going to guess it was the same prehab program for all these different conditions, right? They didn't make a cardiac prehab and a thoracic prehab. No, it was the same prehab format, just trained all their patients before surgery and had benefit across this whole, across all those specialties. I think what we don't know, Alan, is if they were able to segment that data out better, did prehab have a bigger effect on certain specialties, or maybe there's certain, cardiac or thoracic specific protocols that might have had a bigger benefit. But I mean, let's be honest, like practically speaking, even if you just put a standardized prehab program in all these specialties, there's probably benefit.
Right.
And so, I think that was a great piece that they did to actually show that it's a scalable type of quality improvement initiative.
Right. And to have, improvements, length of stay by a full day, across all of these programs, and over $3,000 saved in the post-op 3 months, it's incredible that it's just these four, areas, and it's really simple activity that the patient needs to do. I think it's really neat as well. On the MSHOP page, they actually have reference CT scans of their patients. And so that you can actually see, here's what it would look like in a patient who has prehab versus someone who hasn't. And you'll even notice, even if it's a patient with a higher BMI, you just see the actual quality of the muscles that have been improved and the quality of the scans on the actual tissues.
Yeah, so actually, maybe just to highlight that. So that I'm going to butcher this, but that type of work is called, I think it's called Morphomics. Is a term, and that work, and I think that was kind of the precursor to what they did in MSHOP. So Stuart Wang is one of the other surgeons involved with MSHOP and Prehab, and one of the originators of it. So wanted to give him a shout out because I learned a lot from him as well. And so he did a lot of work on this concept of morphomics, which is basically they did a bunch of, like you said, CT scans of patients who are going to undergo surgery, and what they found was that patients who had stronger core muscles, were maybe like higher BMI, and the ability to withstand the stress of surgery actually did better. So the idea was that using actual anatomy, they were able to find that there's a correlation between that stronger body and better outcomes for surgery, and that correlates very well with why you do prehab. And I don't know, they probably did data on this. I probably just don't know it, but they probably did CT scans too of patients who had prehab and found probably some positive improvements in that core muscle mass and less frailty and things like that.
Mm-hmm.
But shout out to Stuart Wang. He said some great work on morphomics there that are really relevant to prehab.
And I think as well, like there's more studies out today than obviously back in 2010, 2013. But what's interesting is now there's new research on not only length of stay that's being improved, but there's other outcomes like recovery time in general. It's like, I know there was a study led by Francesco Carli and Liane Feldman at McGill back in, I think this one was completed in 2013. So it was one of the earlier ones in Canada. And it was a study on colorectal surgery patients, and they did a prehab intervention. They took a look at, I think it was over a 2-year period or 23-month period or something. They had maybe a sample of 40 patients on prehab and 40-ish patients controlled. And what they were looking at was a couple different measures, but one of them was their functional walking capacity. So how far can a patient actually walk in 6 minutes? It's kind of the 6-minute walk test. And then the secondary measure that they were looking at was the self-reported physical activity. So what do patients actually feel about their physical activity, as well as quality of life? And what was really neat in their findings was for the prehab group, at every single check-in that they had along that 23-month period, the prehab group was able to walk further than the control group, which makes a lot of sense, that conditioning. But then beyond that, after the surgery, it was almost half the amount of time for the patient to return to a baseline function, which I think it's outstanding. If you can just condition your patients beforehand and then have them recover in half the amount of time, and you offer that to any patient, if you say, hey, I have a way for you to recover in half the amount of time, and I'm not sure if it was this study, there's other studies that are out there that we can talk about where their actual pain scores are lower as well. Their reported pain scores are lower. If you can mention that to a patient, you offer them, hey, there's a way for you to recover faster and feel less pain and feel stronger before surgery as well as afterwards. Would you want to do that? And I think every patient in the world would say yes.
Yeah, and I think that's one of the interesting things about when I think about surgery. I mean, I don't, let's be honest, like if you're having a surgery, I don't really know how often or if ever your surgical team talks to the patient about, hey, if you have this surgery, here's what recovery looks like. Here's what your baseline is now, and here's what your baseline will typically be after surgery. Here's how far you can walk after surgery. I don't think anyone talks about that stuff. I don't think anyone thinks about, for most people don't think about successful recovery as as caring about functional outcomes like this. How far can you walk afterwards? How well can you breathe afterwards? Your lung capacity. So I think McGill has done some great work in actually trying to highlight the importance of almost quantifying successful recovery beyond just what was the infection rate, what was the length of stay. It's like, no, actually, how the patient can live afterwards kind of should matter. Which, by the way, often I don't think ties into reimbursement either. Insurers and payers aren't reimbursing for things like how well does the patient recover, what's their functional capacity to breathe or walk properly. They're reimbursing based on length of stay and readmissions and how many surgeries do you do. But I was going to say, I do think it will reach a tipping point where, like you said, the right thing to do is just going to become the standard. So, with enhanced recovery, I think at some point there's going to be a tipping point where ERAS is the right thing to do. People will get reimbursed for it, or it'll just be the expectation. And then it won't just be the people who cared who did it. You know what I mean?
Right. Yep.
And Prehab is not quite there yet. I would say Prehab's probably where ERAS was maybe 10 years ago in terms of how well known and widespread and validated it is. But I would say, 10 years from now, I mean, it would be kind of disappointing if something like Prehab wasn't the standard.
It's interesting that you bring up enhanced recovery as well, because enhanced recovery is, supposedly looking at the entire perioperative journey of a patient. One thing I will mention, Dr. Dan Engelman, he's the president of the Cardiac Enhanced Recovery After Surgery Society. He's actually, and that group has actually incorporated prehab into their enhanced recovery recommendations. So I think that's neat how they've recognized, okay, prehab is definitely beneficial, and we need to include that into the peri-op journey for a patient.
So what you're telling me is that ERAS did an M&A, an acquisition, where they've acquired prehab, and now it's a subsidiary of enhanced recovery.
Exactly. Yeah.
It's growing. ERAS is growing.
I think, but it is interesting because societies obviously play a role in disseminating what's working, and to all the doctors out there. And I think the American College of Surgeons,
maybe on the note, Alan, just because you're on ERAS, so our friend Dionisis Vrochides, who's the ERAS champion at Atrium Health and the president of the ERAS USA Society, they've also been doing prehab in Carolina's Medical Center for their I think their HPB patients, probably some others as well. So for sure, there's a connection between the two. There's lots of folks who are doing both ERAS and prehab, or maybe even just calling it ERAS at this point.
Yep. Well, and I know the American College of Surgeons, they had a big public health campaign called Strong for Surgery, and I think that's even still running today. That was since maybe 2012 that it was kind of implemented or launched back then. And it's basically a quality improvement initiative aimed at implementing prehab, and I think what's neat, the Strong for Surgery umbrella at the American College of Surgeons, what's cool is they've actually put checklists out that are available to the public, assuming that you're a clinician. So you can actually download their checklists, and it would basically have all the protocols marked down, and for providers to actually check off, yes, I've mentioned this to my patient, yes, I've been tracking this. There's probably a checklist in there for, do you have an actual survey collection tool, whether it's paper or a digital patient engagement solution. So I think that's really neat. And they have other, resources available for smoking cessation, for instance. They have different resources available for different measures.
Yeah, and just for folks who don't know, Strong for Surgery was started by Dr. Tom Varghese, who's the thoracic surgeon out of the, I believe, University of Utah. But he used to be in Washington State, where they launched Strong for Surgery, and he moved to Utah afterwards. But he's been a fantastic proponent of prehab and Strong for Surgery, obviously. So definitely worth checking out those resources for sure.
Right. And I mean, I've heard even the term Strong for Surgery at other, I know at Sage's events, I've heard Strong for Surgery, and there's whole talks on that and dedicated to it. To be honest, I didn't know it was prehab until maybe a couple of years back when I really researched into what is Strong for Surgery, but it makes a lot of sense.
I think I'm just I look at some of their resources. They kind of put prehab as part of Strong for Surgery. So they've added a few other things around it. So there's overlap, but they've added like some other specific protocols as well. So I think if let's say you've done prehab or you're looking for something bigger to do, it's definitely going to be a good resource to look at.
Right. Now, what about some of the partners who we've actually helped with prehab? I know there's some prominent groups in California, for instance. There's Dr. Cindy Kin, who's an excellent general and colorectal surgeon. What have we seen with prehab on SeamlessMD or with some of those groups?
Yeah. So, we met Cindy at Stanford several years ago, and it's a funny story. So, she reached out to us after she heard about us from, I think, an anesthesiology colleague. But for her initially, the interest in Seamless was about just not for her patients not to have to deal with, like a 50-page binder about guiding them through a colorectal surgery. But then, and so I think initially the goal was to use SeamlessMD for enhanced recovery after surgery for colorectal, which is what we did. And we did some great work with her. But she also had an interest in rehabilitation. And so what we did was they had already done, I think, prehab, I'll call it manually, so on paper and verbal instructions. But I think one of the challenges that they had in their group was that it took a lot of staff time to be educating a patient on prehab. There was no accountability, so no one's checking in with the patient. How many steps did you actually walk? Are you walking, 5,000 steps a day? Are you doing your Mediterranean diet? And so we basically helped digitize that protocol and then added that prehab, essentially those prehab workflows onto their colorectal ERAS version on SeamlessMD, so that patients were being reminded to do their exercise. We were prompting them to walk at least 5,000 steps a day. They were getting education about their Mediterranean diet, about smoking cessation, whatever was in their protocol. And they actually did an analysis where they actually compared, I think 250 colorectal surgery patients on prehab on SeamlessMD with a control group that wasn't, and they saw statistically significant reductions in I think in pain scores, opioid use, Tylenol use, through this combined digital prehab and digital engagement platform. So that was actually a really, really great experience for us doing prehab with her team there. And I think actually we can link that, Alan. There's Stanford actually wrote a story about that work that we can share if people are interested. But shout out to Cindy Kin and her team at Stanford for continuing to do fantastic, innovative work in the prehab space.
Yep, definitely. And I think, mentioning these 50-page binders that would be for an enhanced recovery program, obviously we're all human and we like to get information in bite-sized chunks. That's why, Twitter's done so well as an example, but it makes sense. And if you can distill information down to the shortest form, then you're more likely to get compliance around that. How does SeamlessMD kind of support that prehab work? I'm assuming it's delivering the actual content to the patient, but is there anything more to it?
Yeah, so it's, remind them to actually meet certain protocols for let's say exercise or walking. So it's not only telling them to walk a certain number of steps every day, but it actually helps them set goals for how many steps they want to walk and helps them track accountability for it. The care team can monitor that too if they want to, and then maybe call up patients who are falling off track and not maybe mobilizing as much. It educates them with content on proper nutrition, tracks that they're following it. If incentives spirometry is important, as it would be for let's say groups in Michigan, then you could use it to again remind patients and track compliance with incentive spirometry, point to content on mindfulness and positive thinking. And the idea is that imagine you have a big department of surgery with 10 different divisions: cardiac, thoracics, abdominal wall, reconstruction, gynecology, everything. You could literally create a single prehab program on Seamless and then just enroll every patient on it. And frankly, you don't even need to have someone to monitor it because so much of it is self-guided.
Right.
And the idea is that traditionally you'd have to hire all these staff members to educate patients on prehab, but instead you can just put them on Seamless, guide them through prehab, and then reap the benefits of that scalable digital intervention. That's the power of being able to do it at scale. And that's what makes prehab really exciting, that unlike enhanced recovery, prehab specifically doesn't have to be so tailored to each clinical specialty. you can truly do what Michigan did and deliver a standardized prehab protocol.
Yeah, totally. I think, it would be interesting as well to do a deeper analysis. I think maybe you mentioned this earlier, but to figure out maybe there are some differences within these specialties that could really take it to the next level or something like that. But, and I think that's also where digital technology can really play a part is, let's say, you have a pre-existing prehab program and you want to make a change to that program. Well, if you have it all in paper and all in binders, you have to go through and sticker over all those mentions and fix it all up. Whereas with digital technology like SeamlessMD, you can make that change in one place, and then all of your patients in the program will receive that update. I think that's really cool
or even
well.
just like, let's say you're a big 50 hospital system and prehab's going really well on a digital platform at one hospital, and you want to suddenly get into the other hospital. It's just so much easier if you can just add in the other hospital on the platform and disseminate the patients. I'm oversimplifying the process. You obviously have to ensure the clinical team is aware of it and things like that. But the delivery of it, once people are bought in, is just so much easier at scale.
Yeah, in my head, that might reduce some of the friction to getting patients all on a prehab program.
Mm-hmm.
I think there's, and you mentioned this earlier, but there is this belief probably that, I'm as a surgeon, I'm already giving that instruction to my patient, but there's not that accountability aspect. There's not that actual tracking and making sure that the patient's actually following the instructions. So that's where the digital technology can really help with, hey, if you want to get your program on prehab, you can just move it over to that program or the next hospital that's part of your system. It's as easy as setting up a new link, or that's really it.
Absolutely.
I think, in my research, there's a ton of papers out right now on prehab, especially in Europe and across the world. And there's starting to get more and more research that's coming from North America, Canada, and the United States. Some of the prevalent prehab programs that I've heard of, obviously the teams that, we work with and are quite familiar. But, for instance, like Stanford and Cindy Ken and Atrium Health with Dr. Vrochides. But there's also other groups. We've mentioned the MSHOP. University of Michigan is obviously a big one with Dr. Engelsbe, Francesco Carli and Liane Feldman, obviously huge work in McGill. But there's other teams as well out there. I know I read around, there's some UCSF. They've been doing some great work led by Dr. Emily Finlayson. I'm probably butchering her name. Finlayson. Emily Finlayson.
You have to invite her onto the podcast so she can correct you.
I'll reach out to her, actually. That's a good idea. She's honestly done some amazing work looking at frailty and prehab patients. But I think it is pretty cool how you've mentioned, it's across different specialties as well. So, that was for the Department of Surgery, but there's neurosurgery work, and Mount Sinai in New York has done some great prehab programs with neurosurgery. There's urology teams at Brigham Women's, for instance. Do you know any of those teams or anyone else who's actively involved in that?
No, I don't know those teams, although I hope that they listen to this podcast and get excited about talking to us.
Yeah, definitely. I mean, I think in addition to having these checklists that they're putting out, there is another step and there is another component that can really make their life easy and make patients, engage with their programs that they want and to get those better outcomes. And, summarizing again, it's outcomes around length of stay, it's outcomes around recovery times, pain management, quality of life has improved, feeling stronger. There's just a ton of improvements, and it seems like such a simple activity. Something else that we didn't mention, typically when you're scheduled for an elective surgery, there's a period of time that you have to wait before your surgery date anyways. So why not get the patient actively involved in their care earlier? It just seems like a no-brainer.
Yeah, I'll tell you, one of the interesting things I've heard, and there's a bit of controversy, I think, sometimes between people who want to do prehab and those who may not want it, is if there's some surgeons or anesthesiologists who feel that every patient should get prehab if they're having major surgery, even if that means delaying the actual surgery date by a couple of weeks to give the patient a better chance to recover. There are certain surgeons who are against that, saying, no, I don't want my surgery date delayed by a month if I can book it in next week. So there definitely is still some ongoing, I think, debate between different parties about, how much prehab time should they have, and is that worth it if it's risking delaying the surgery. So I think that still is being sorted out. But I think the body of evidence suggests in general that, hey, if you can prehab a patient, you should prehab a patient.
Right.
One other thing that I actually, we kind of glossed over with the work that Dr. Cindy Kin has done at Stanford is the fact that, like with prehab patients, the opioid use went down, the pain went down. I mean, we keep talking about with opioid reductions, prescribe less pills, but look at the fact that there's interventions like prehab, which reduce pain so that patients need less pills in the first place. That's phenomenal. I mean, like, why aren't we looking at more interventions that reduce pain in the first place?
Right. Totally.
I mean, that's actually I don't know if I've seen many clinical work done showing that prehab reduces pain and opioid use. That's actually pretty compelling.
Yeah, I agree. There's probably a ton of studies that would be really beneficial to have at this point. More studies of the same nature that Dr. Cindy Kin has done, but I would like to know, what amount of time or what amount of intervention is, going to bring that 80% of the result. And maybe it isn't 4 weeks, maybe it is, only 2.5 weeks. If you can fit that into a prehab program, that's where you get 80% of the benefit. That would be interesting to see as well.
Yeah, it ends up being like what's practical. So I think people end up figuring out like what's a practical amount of prehab that we can get most people to buy into that has the biggest benefit. So like maybe you can't get every patient or provider on board with the 4-week prehab program, but maybe you can get them on board with a 2-week program and that still has major benefit. I think we'll have to see how that goes.
Yeah.
But yeah, it's one of those things where things can work well in a confined setting, but then what do the parameters have to be for it to successfully get adopted and scale? I guess we'll have to see.
Yeah, it's exciting. I mean, it's neat that this is kind of the forefront of what's happening in surgery right now, and it's exciting to see where this is going to go.
Absolutely. And hey, I know we don't let our viewers into the podcast so much, but I'll throw it up there. If there's any viewers who have certain topics that they want us to cover, whether it's related to digital patient engagement or kind of loosely related, let us know. I think we're very open-minded. We want to explore new topics that are helpful. So reach out to Alan, reach out to myself. Let us know if there's something you want us to dive into. Or also, there's certain people you want to join. We got some guests lined up, but we always pander to the crowd, right, Alan? So
exactly,
people get.
And to piggyback off of Josh, I mean, in order to get the word out there, please share the podcast if you found it, the information in here relevant and exciting. Then please share it around with your contacts, like, comments. Let us know what you think of the material. Yeah, like, comment, subscribe. Yeah, I feel like a YouTuber now.
Yeah.
But yeah, I've enjoyed learning about prehab. I think it's an exciting topic, and it seems to, it's improving outcomes across tons of different areas. And, obviously with the opioid crisis, we just released that podcast, but if this is another modality, another intervention that can help in that cause, then, that's amazing.
Absolutely. Awesome. I really enjoyed this, Alan. Thank you for taking the time as always.
Thank you, Josh. All right. Have a good one.
You too. Take care, Alan.
Bye.